After such a beautiful talk, it's a very basic talk. So I'll be talking on branch retinal vein occlusion and its management.
Tripti.
Learning objectives, mainly to diagnose and how to manage. So this was first described by Theodor von Leber in 1877. So this branch vein occlusion refers to the obstruction of a branch of the retinal vein at arteriovenous crossing. The compression of the vein is thought to cause endothelial cell loss, turbulent blood flow, which leads to thrombus formation. It is the second most common retinal vascular pathology after diabetic retinopathy. Most commonly seen in superotemporal quadrant and also in inferotemporal retina. Nasal involvement is rare and usually is asymptomatic till neovascularization causes a vitreous hemorrhage. So this is the classification. Major and macular. In major, it is major at the disc, away from the disc, and peripheral. Macular when it involves the macular bundle. So these are the few pictures. The main risk factors are age, increasing age, hypertension, hyperlipidemia, diabetes, glaucoma or ocular hypertension, oral contraceptives, smoking, increased BMI at 20 years of age is also contributing to a risk factor. The uncommon risk factors are dehydration, myeloproliferative disorders such as myeloma, polycythemia vera, thrombophilias, wherever there is increased hyperviscosity of the blood, hyperhomocystinemia, inflammation which can cause occlusive periphlebitis. Other risk factors are Behçet's sarcoidosis, Wegener's granulomatosis, orbital diseases, chronic liver failure. Even in retinal diseases such as Eales disease, toxoplasmosis, Coats disease, it is also seen. So the diagnosis is mainly when the patient complains of the symptoms, and the symptoms depend on the location of the vein occlusion. So if it is far away in the periphery, patient might not describe that he is having any problems. But if it's involving the macular region, it is a painless blurred vision, often accompanied by metamorphopsia, and iris neovascularization and neovascular glaucoma are also seen in 2 to 3% cases at 3 years. So the fundus picture is typical, and the diagnosis is mainly on seeing on fundus. So dilatation and tortuosity of the affected venous segments will be there. Flame-shaped hemorrhages may be there, also dot blot hemorrhages, few cotton wool spots, and retinal edema can be present. More commonly in the superior branch vein occlusions where the fluid descends to the macula. After the acute phase, it resolves in 6 to 12 months. The vessels may have sheathing and sclerosis and might lead to persistent and recurrent hemorrhage. Neovascularization, 8% is seen if there is more than 5 disc diopters of non-perfusion. So these are few images. Here is this is a fundus photograph, and here this is an OCT image showing cystoid changes, macular edema. The investigations which we have to look for in systemic is blood pressure. Mostly the blood pressure is elevated in such patients. ESR rate, RBS may or may not be increased. We have to do a lipid profile also, and the other tests which we have to see for end organ related tests such as urea, creatinine, and thyroid function tests. We should also do a echocardiography. Chest x-ray we have to do. Plasma homocysteine level, it's seen raised in most of the cases, and all these carotid duplex imaging should also be done to exclude any ocular ischemic syndrome. Diagnosis is mainly clinical, and we do OCT to quantify macular edema for regular follow-ups. Fluorescent angiography will show venous filling defects, blocked fluorescence, and capillary hyperperfusion. These are the few pictures. These are taken from Kansky, not my own pictures. So you can see blocked fluorescence, and here collaterals and neovascularization. Okay. OCT angiography will show the loss of vascular blood flow and retinal microvascular telangiectasias. OCT-A cannot differentiate between collateral and neovascularization. Management, what we do is, if there is macular edema, we inject anti-VEGFs, And once the hemorrhages have resolved, we do sector laser photocoagulation. So these are the few studies. This is the picture depicting the scatter laser photocoagulation. The size is, spot size is taken between 200 to 500 microns, and one burn apart. Anti-VEGFs, the other VEGFs which we use are bevacizumab, ranibizumab, and aflibercept has also come. So even we are using, for non-affording patients, we can use triamcinolone and Ozurdex. Thank you.
I think BRVO mainly, like, we want to rule out any systemic cause,
Yes, sir.
and especially so if it is not vision threatening.
CRV?
Sorry?
CRV? But sir,
Yeah,
whatever
but
we
like,
have seen in BRV,
what I try to do is we try to, whether it is kind of any vasculitic lesion, cause, or any like blood pressure or hyperlipidemia cause. Plasma electrophoresis and all, I don't know if many people are doing. Are you doing, sir? Sir, will you be required? And the other thing is we just keep counseling them to keep a regular follow-up, and same is for pachychloride, but in India that is an issue. People don't follow regularly. I usually tend to say that this is kind of a precursor to a hemiparesis or kind of a stroke which you might have sometime. So you should take care of your systemic illness if we are able to find some. Sometimes even a carotid bulb plaque we are able to pick up. But those are only few things if we are able to pick up. That's all. And scatter laser we are not doing as a routine, only in case
hemorrhages, like
no,
if they have vitreous hemorrhage and...
No, vitreous hemorrhage of course will occur only if there is a neovascularization. And if there is any evidence of neovascularization, especially so in the sector, then only we do pan-retinal or sector laser photocoagulation. CRVO, of course, we treat more aggressively compared to a BRVO. I think sir would agree with me.
Yes, I think what we should be doing is, at least we have followed. If you look at the large studies, and we have also seen that 90% of the branch retinal vein occlusion is because of hypertension.
Yes.
If you have established that, don't go into that many investigations. We believe that. And as already mentioned by Dinesh, you see, you have to tell them there is a stroke in the retina. It's a stroke. So if you tell them, they take very seriously. Okay. You tell them this stroke could have happened in the brain or in the heart. So then they are very serious. Then they won't neglect. So I think it is a stroke, basically. Yes. So it is exactly akin to that. So I think that's how the better counseling prevails over a period of time. We learned by our own experiences. And of course, the treatment we know, you mentioned these days, anti-VEGF remains the main, and we should counsel them well. They may be lucky, especially BRVO require much less number of injections as compared to CRVO, we all know that. But then still, there are maybe around 30 to 40%. They may need long-term, over a period of time also that happens. But if they fall in that other group, then after some time they may not need it. So I think that is what.
They sometimes land up with other eye BRVO.
Yes.
Yeah. Absolutely. If you don't find hypertension, I would say, because then we need to investigate accordingly. But not all investigation, what has been mentioned, of course they are important, they cause it, but not that every investigation, what is happening these days, we put battery of investigations, so that's not the way to. Yes, yes.
COVID, of course, at that time it increased the incidence. Even some people reported, I think, post COVID vaccination.
Yeah.
So, but now it's going down a little bit compared to what we had, because the number of cases were more, so also the complications.
homocysteine is raised.
I think you be careful about this homocysteine business. Once it is done in the population, majority of the people have this. So it's not a lonely factor which is causing this. That's where we are going wrong. So I think they are being treated left and right. We see all the time. And the problem is, if you look at and do homocysteine for many people, they will have high. So alone, it's not really something which should be considered that seriously. It might have contributed some way, but not. Then you need to consider in young patient other things they may have, which might be more serious than a homocysteine. That is what my take on that is. Thank you.
Thank
I think
you,
we
sir.
proceed further.
Thank you.